Joining today. I am going to take a very high level Hospice 101, but I really want this to really mean something to all of you. So if there are specific questions that you would like addressed or things that you want me to dive a little bit deeper into, I'm screen sharing, so I won't be able to see them, but Daisy's going to be looking at the chat. So feel free to use the chat function, and she'll also be looking at the question and answers. You should see that at the bottom of your screen. So she'll stop me and we'll be able to tackle things and have a real conversation here, even though you're muted. So thank you, Daisy. I really want to talk about both the hospice benefit, which is a federal benefit, and I want to talk about the philosophy of care in hospice as well. So pretty typical. I have no disclosures to report. You all know that I work for Accent Care and I serve on these other councils. And today's objectives are to look at what hospice is and what it isn't. So there are definitely some myths, and we'll talk a little bit about those myths today. I want to talk about who qualifies for hospice, and there are some variations, and we will talk a little bit about some specific things that happen in Florida. There's a uniqueness there, so I want to make sure that you all are armed with that information. We'll talk about how to connect steps for hospice referrals. And so I'm going to talk about that in two ways in case we have any community refers here. And also, of course, we have the community here. So I'll talk about both. Daisy, I will make you keep me honest to make sure that I do that. And I'm going to show you a couple of questions that as family members, loved ones, ourselves, all of us, no surprise, will need end-of-life care at some point in time in our own lives. I'm going to show a couple of things that you may expect to be asked and conversation starters, and also ways to flip some of that conversation that you can ask your physicians, your providers, your nurses, your teams that are serving you in any other way, shape, and form. So that's really what the objective is today. So let's start with a little bit of the hospice history. And Medicare's definition of hospice. So I'm just going to read this. I know we all can read it, but just for those who are having a harder time seeing or who are listening by phone. Hospice care means a comprehensive set of services described of the Act, identified and coordinated by an interdisciplinary group. So we'll talk a little bit about the interdisciplinary group to provide for the physical, psychosocial, spiritual, and emotional needs of a terminally ill patient and or family members as delineated in a specific patient's plan of care. So we'll talk a little bit about what that really looks like and what that means, who that interdisciplinary group is made up of, and what does terminally ill mean in the definition of the hospice benefit. So we'll kind of break each one of these pieces down as we go throughout today. So let's talk a little bit about what's kind of unique to Florida. So depending on where you are in Florida, you may have access to multiple hospice providers, or you may have access to a very limited group of hospice providers. And here's the why behind it. Florida is a CON state. CON stands for a certificate of need, meaning kind of what it sounds like, that there is a regulatory process. There has to be a proof that the providers that currently exist, so your hospice teams, your hospice agencies that currently exist, cannot offer the care that is needed for the community at any given point in time. And so it's broken down in counties, as you can see in this map. Apologies on the colors. I wanted to pull this from a local site. And so what would happen is, let's say you're in a community that has a small or only one or two hospice providers, but there is a population, and in your population, there's a need for more patients, or more patients are eligible for hospice services and community members are eligible for hospice services than, let's say, those two hospice providers can give. Nobody can just open up a hospice. So what has to happen then there are public hearings. Any agency who is trying to come into that county has to demonstrate what that need, so that's where the certificate of need comes from, what that need designates and shows in that county. So there need to be more eligible hospice patients than there are currently providers who serve. So this can be really unique in Florida. It's not the only state that's a certificate of need. There are fewer and fewer certificate of need states, but it is what may make it harder for you in some areas and some counties to access multiple choices versus in other counties where you may have a lot more. So in Dade County and Broward County and Palm Beach County, you can envision, if we walk over to the Gulf side, Hillsborough, Pinellas, even Pasco and Hernando counties, there are more options than there may be in other parts like the Panhandle in Florida. So just wanted to kind of explain what makes your state unique to you. All right, let's jump into the hospice circle of care. So the hospice benefit officially began in the United States in the early 1980s. And it was obviously presented as a way to provide care for the terminally ill. And what does that really mean in terms of the benefit? Well, it means that an individual with some sort of illness, if we were to remove curative measures and instill aggressive comfort care instead, and just let the disease run its course, most likely that lifespan is now 6 months or less for that individual. We'll get into some nitty-gritty there because oftentimes 6 months or less really terrifies people. It's kind of scary even to me working in this field for over 20 years when I hear that, because not all of our patients die within 6 months. Some die much sooner. Some die many months or even a year or two later. And so I'll explain how that happens and why that happens. But the idea is somebody has to have a life-limiting illness. And at this point in time, the focus, as opposed to where let's use cancer as an example, where it may have been curative focus, like aggressive curative care to try and beat the disease or to try and prevent the disease from spreading. In this case, the focus becomes aggressive comfort care. I use that terminology. I use aggressive in both. That is focused on preserving quality of life and preserving hope and dignity and comfort. And so most people think about hospice as this is where we go, where we die, or this is the time to die. And what I will share with you as a hospice clinician who spent a long time in the field, my number one job is to make sure that the death event itself is symptom-free and comfortable in a way that every individual may want it to be. So it's going to be unique to each person. But my second most important role is to help people live until they actually die. And we sometimes forget the living part of the role of hospice. And so here's where the living comes in. It's in this entire circle of care. So we have the hospice patient at the center of this. That's our terminally ill individual. Then we've got that next circle. I call this the chosen family. It's family, it's friends, it's the individuals that are most important to you. And then hospice has to provide all of these different individuals around you, or at least not all of them. I'm going to exclude music therapists for a moment, though in most Florida hospice agencies, you do have board certified music therapists, which is exciting to me as a board certified music therapist. But we have to provide you with a registered nurse. That's typically your case manager. They're the eyes and ears for the physician who will come on a specific schedule to the bedside. There is a medical director that oversees care for the larger team. Every team has to have aides, hospice aides, to help with the care and dignity in the day-to-day. Social workers are a requirement, and a second counselor who has to be able to provide spiritual practice is a requirement. And most hospice agencies will have a chaplain, or sometimes they'll call that a spiritual care counselor. And that person's role, I always want to highlight, is not necessarily focused on religion. Not all of us are religious or faith focused. Some of us are really spiritual, and that's really their primary role. So spirituality is the umbrella, and then religion underneath that. So this is sort of what the whole team looks like. On top of this, there are other things. Anything related to the hospice diagnosis, medication-wise, has to be provided by the hospice benefit. Anything like durable medical equipment, let's say our hospice patient in this scenario wants to stay and die at home. Many of us do. So they may need a hospital bed. So that's considered durable medical equipment. Maybe they need oxygen in the home. All of those items are a part of the hospice benefit. And depending on the kind of level of care, and there are 4 different levels of care in hospice, that is reimbursed, whether you're a for-profit hospice or a nonprofit hospice. That comes up a lot. That is reimbursed on what we call a capitated rate. So there's a per patient per day rate that every single hospice receives based on the level of care that that patient is in. All right, Daisy, are there any questions before I keep moving on, or any comments or anything that we want to highlight for everybody?
So far, we're good. I think everyone's enjoying your presentation. So far, good.
I see Kathy raised a hand. I don't know if she can unmute or not mute, or if that's, or Kathy, are you high-fiving me? That's how I see virtual raised hands.
That's how it is, yeah. If you do have questions, please go ahead and drop it in the comment box just so we're able to see it. Seems like we are not able to have people openly mic on here.
Kathy, go ahead and drop it in, and let me take a quick. What's the difference between nurse, social worker, and aides? Really good question. Let me live answer that for you. Let me go back. So the registered nurse, the nurse's role is mostly physical symptom management and support. So let's use cancer. Let's use cancer as our hospice patient's diagnosis again. I'm going to use some scenarios with you. So our hospice patient's diagnosis is some variation of cancer, and the nurse's role is all of the symptoms that the patient may experience: pain, they may have anxiety, they may be struggling with some of their mobility and like their walking and the things that really bring them quality of life. So the nurse's focus is to create a plan of care around that. And it's to communicate, again, being the eyes and ears to the medical director, and to communicate what they're seeing, to talk through what sorts of supports they may be able to offer, and then to ensure that those symptoms and the pain is being managed with both medications, so what we would refer to sometimes medically as pharmacologic, and things that are non-pharmacologic, so it might be related to music therapy or spiritual care or support, because we all know that we're not a human based on just symptoms. There's so much more around us. So that's where the nurse's role is. The role of the social worker is typically more related to the counseling, psychosocial. It may be related to some of the financial pieces. So when we did the definition at the beginning, remember we called out Medicare. So it may be that our hospice patient in this circumstance doesn't have Medicare or Medicaid, but is eligible for Medicare or Medicaid. And so the social worker may be supporting that financial element. And then they're supporting a lot of the sort of counseling elements. I know all of these different disciplines we sometimes think about, they kind of have, some of them have both positive and negative connotations. So in this case, the social worker's role is not necessarily to divide out family from patient. It's to counsel and bring everybody together. And then the hospice aide is working underneath the registered nurse. So the registered nurse you would think of as the supervisor for that hospice aide. They're doing all of the physical day-to-day. Now, they may not be at the home every single day, but they're providing care like helping with cleaning and bathing and sort of what we call activities of daily living. So sometimes it's feeding and supporting nutrition and those sorts of elements. So think about them as doing some of the most intimate care and support with the patient. I hope that helps a little bit. I hope that answers your question, Susan.
We do have a couple more questions.
Yeah, go for it. Let's do it.
Sarah did ask, I know hospice is paid by Medicare. Do regular insurance policies also cover it?
They do. And so this is the gift of hospice being a federal benefit. Even though you're within the Florida, one of the counties in Florida, private insurance companies have to provide what's known as a carve out for hospice.
Thank you for that. And then we have another question by Kathy, and they're wondering if you must live in the county that you receive hospice, like one nearby, can you use that?
So that's a great question. So the answer is kind of a yes and no, and I don't mean to make it complicated, but the hospice agency, you don't have to live in the county where the hospice agency provides you care, but that hospice agency has to have that right. Remember that certificate of need, they have to be allowed to operate in that county. So they may be in a different county. As long as they're licensed to provide care in your county, they can still service you. The hospice will be able to tell you that. And most likely, if a hospice is in your county, they are licensed to provide care in your county. That's what makes things a little complicated.
Thank you for that. You clarify so much.
Is there any more before I jump into a couple of hospice myths? I have a feeling we'll have some conversation there too.
So far, we're good. If you do
Okay.
have questions, don't forget to type it in the question box.
Yep, happy to stop at any point in time. We made this lean so that we can answer all of the things that are important to you. Okay, first hospice myth, and I think we sort of acknowledged it a little bit, is that hospice is for the people who die within a few days. So if we really think about the whole purpose of hospice, and we think about it from the perspective of the two parts of the puzzle, right? One is dying with dignity, grace, comfort, whatever that means to each patient, each hospice patient. If we think about that part and we think about the other part, which is living to the fullest of your ability within the constructs of that illness, then if we only have a few days, some of the things that hospice can do that's really special and beautiful around family work, and I mean that in terms of chosen family, friends, your community, whoever your community is really, really, really hard to do. And for any one of us who's experienced a death of somebody with a more chronic illness or a terminal illness, and I don't mean a traumatic death, which was unexpected, sometimes with a chronic or terminal illness, when somebody dies that quickly, for us as family, or friends or anybody in their circle, it's really, really, really hard on us. It feels more like a traumatic death. So when I think about my own end of life experience, and it's in my advanced directive already, and I always encourage people to think about this when we have our mental faculties to do so, especially since many of us have experienced deaths in our lives. Um, I I have hospice listed when I'm at the point, as soon as I am in a condition where I consider it's considered life limiting. So it may not be a chronic illness anymore that I'm living with for 20 years, but it becomes very life limiting and closer to the end. I want hospice for myself, and I want it less so because I want the support system for me, but I want that support system for my family. And we'll talk a little bit about that. So there is a difference between adults and pediatrics. So children, we do hospice, people die at all ages. So in the Medicare hospice benefit, the federal benefit for adults, we've got the prognosis, so the lifespan approximation of 6 months or less for the adult population. So typically anyone over the age of 18. And then for pediatric cases, so for infants, toddlers, children, young adults, adolescents and young adults, it's a 12-month or less prognosis. And part of the reason is the illnesses that we see in the adult population are very different than the illnesses we see in the pediatric population. And if you can imagine, again, the living for as long as is possible and then dying with dignity, so both of those things interacting, in a pediatric case, there's a lot more. Oftentimes there's many more community members, including a lot of other children to support throughout the process. So currently in our agency, the average length of stay, meaning how long most adults are receiving the hospice benefit, is around 67 days. And if you're asking a hospice clinician, that's too short. I love getting the privilege of spending time and learning about a patient's story and their family's story. and being able to help them build a legacy. And so 67 days, we can do a lot with 67 days, but it's always better if we have 68 or 69. And so what I ask the community is, this is where we get to partner together to help make that happen by empowering all of ourselves to speak up when we're talking to our physicians, when we're when we're experiencing a chronic illness that we know will limit our lives. I see that there's a couple of questions or comments coming up. How is hospice different from that of a death doula? Great question. So the whole role of the death doula is the death process. It's the active, what we know as the active death process. It's the part of life that happens towards the very end. And sometimes that can be a few hours, and sometimes those can be a few days, and sometimes that can be the last week or two of life. That's the role of the death doula, is to make that process from that active death phase through the death event itself as dignified and supported. Hospice starts before then and crosses over. So there is an overlap. And many hospice agencies, ours as well, work with death doulas, and we use our death doulas to train what we call vigil volunteers. They support patients and families by being present more towards the end of life. And so there is an overlap, but hospice does all the living part up until the active death part, and the death doulas typically step in for the active death part. So it can be a good parallel together. Okay.
I think we're all caught up.
Perfect, thank you. Okay, the other huge hospice myth is that hospice is a place, that it's a place where you go to die. And this is probably the biggest myth of all. I don't know how many of us want to die in a facility like a nursing home or an assisted living facility or a hospital. That's true. Some people do want to die there. Most of us, and most what I hear from the thousands of patients I've been very honored to serve, want to die at home, wherever home is. It may be in their own home. It may be in the home of one of their children, of a partner, of a friend, but they want to die in a home. They want to die in a place where we, as the hospice clinicians, are the visitors. We're coming in as a support, and this is their familiar surrounding. And so I'm going to tell you all a story, and I'm going to do my very best not to cry. It's one of my favorite hospice stories, about a patient who was houseless, or homeless, the more familiar terminology. And he was on service for congestive heart failure, which can be extremely, extremely hard to prognosticate or to anticipate a death date because of the way that cardiac conditions typically develop, and those illnesses develop. And he had been houseless and homeless for a very, very, very long time. He was a Vietnam veteran. So if that kind of gives you a framework of what his experience was coming back, I know we just passed Veterans Day for those who served. Thank you very, very much. And those who are serving. But his experience, really, that experience of his time in Vietnam and his time coming home really flavored the rest of his life. And so he lived in an encampment underneath a bridge. And when he first came to our hospice services, he was extremely sick. He had just had an acute event. Obviously, he was extremely sick. He had just had an acute event, like kind of a traumatic event in his illness, and it landed him in the hospital. And the emergency room physician was the physician who actually made the hospice referral, because they had seen him many times in the emergency room, and they sort of got this sense, I'm going to call him Jerry, that Jerry was getting closer and closer to the end of his life. They were starting to see certain things develop. For those of you who are more familiar with cardiac conditions, he was starting to have some of the edema, or like the holding back of the weight, the liquid weight in his legs. They were starting to see that. They were starting to see some discoloration. Obviously, he was having more frequent times in the emergency department for cardiac incidences. And so they made the referral to us. And because he was so sick and we couldn't get him back under that bridge, we brought him to one of our units at the time. And one of the things that was really hard for Jerry was he felt like when he was feeling a little bit better, like he was taking a place from somebody else. And so he tended to escape or elope from the unit. And we always knew the trigger for it. He would sort of ramp up the last few days, telling us that somebody else needed that bed more and they deserved it more than he did. And so we always knew that it was coming, and we always knew where to find him. And he had told us that early on. And so we would find him in the bridge. And so we ended up having a couple of scenarios where he landed back in the emergency department, landed back in our unit. And we just decided this, he just kept leaving, and he clearly wanted to go back to his community. And it was really, really important. So we served the rest of his hospice term, and the rest of his life under that bridge, getting to know his community and his chosen family. And it's complicated to do that because, of course, there's medications, and how do you, the aides that we just talked about, the hospice aides, like they can't provide care like that in the street unless he was covered in the tent. It took a lot to coordinate care for him, but to him, that was home. And it was the most important thing for him to die in that community. And one of the hard things is I was working in the South Bronx at the time, so that's an important piece to the story. There was at the time a gang war occurring, but Jerry had been so well known that we sat down with the two heads of the gang to coordinate, and they actually did two things. One, they served as his community to help him. So they took rotations to sit with him, especially when he got closer to the end of his life and he was no longer able to voice what he needed or wanted. And we were looking for all of the nonverbal sorts of signs. And two, they made sure that the hospice team was safe getting to and from, let's say, the subway or the bus stop or wherever we parked our cars to that bridge to serve Jerry and to support him. And he got to die there. And one of the things that was really important to Jerry, and what he loved and what he was known for was flowers. And the day after his death, after we were able to take him from that place in a way that was really dignified, he had an extremely peaceful death, a lot of people around him, including the hospice team. When we came back to check on the community, the two gangs had come together and collected all of the flowers that were being given out by the florists all around the community, and came, and this entire bridge was just covered in flowers for Jerry. So I say that because I think it's such a myth that we serve in a place. And I think it's really important for the community to know that wherever it is that is important for you to be, with the people or the things that are important for you to be, hospice teams are constantly trying and yearning to make that happen. And so the partnership is really you all sharing that as we all get closer to the end of our lives, is really being able to share that. And I think one of the important pieces to know is that hospices provide, even though we're not necessarily with you 24/7 on the journey, we do provide 24/7 care. So at Accent Care, for example, we have a 24/7 call, like a 24/7 support line, and it's manned by nurses, by registered nurses. So if Jerry or one of the community members were to call us and say, hey, he's experiencing this is what I'm seeing, they would be directed on how to help that while we deploy somebody to get to him, while we send a nurse to get to him, because we really also want to preserve the family, the chosen family, having time with that patient simultaneously too. So biggest hospice myth. So thank you guys for letting me share Jerry's story. He has always permitted me to share it, and it's been very special to me, obviously. Another myth is that hospice is for cancer patients only. And I think this is the hard one. There are a number of different diagnoses that are life limiting, and many of us know that. So you can see some that are listed here. There's ALS, there's chronic obstructive pulmonary disease, there's Alzheimer's dementia, Lewy body dementia, or vascular dementia, there's renal diseases, there's cirrhosis, there's Jerry's example, congestive heart failure. So there's a lot of different diagnoses. And one of the challenges in hospice is that each diagnosis has a very specific set of guidelines that say that this is when somebody's approximately 6 months or less. So what somebody who experiences ALS may have a different set of requirements for their eligibility to the hospice benefit than somebody who has cancer or who has congestive heart failure or has Alzheimer's dementia. And how we provide care for somebody is we use what we call certification periods. So for somebody's hospice admission, their first admission to hospice or any other one, we have benefit periods. And so at the very beginning, there are 2 60-day benefit periods, so 2 months each. And then following that, there are 2 90-day periods, so 3 months each. And then following that, there are 60-day periods after that. And so the entire interdisciplinary team comes together to take a look at whether the individual is still meeting criteria based on their diagnosis and based on what's happening in the trajectory or the way that their illness is moving forward. And so that's sometimes when you hear stories about individuals who have either graduated from hospice and they didn't die on hospice services, or they came back later because maybe they had, like Jerry, an acute event that landed them in an emergency department, and with the right level of care at home, they actually were able to graduate from hospice because they actually didn't continue to meet the criteria for their diagnosis. Or individuals who continue to meet the criteria and are on hospice for months and months, some people for a year or more. And so that's really what makes part of that up. I see that there's what if the patient lives beyond 6 months? So Estrella, great question. And that's really where it comes from, is the person may live beyond 6 months, but if we're looking at each of those benefit periods, and the interdisciplinary team partnered with the patient and their chosen family are seeing what you'd expect to see in a decline. Sometimes it's even very, very, very small incremental changes that will keep them on the hospice benefit and receiving the hospice benefit for a lot longer. So it's very, very nuanced. It does get very complex, which is why having an end-of-life team, a hospice team that does this day in and day out, can really, really help. And here's one of the things that's our responsibility, and I want to empower anybody receiving that care to speak up. Our job is to help consistently train and educate our patients and their chosen families for what will happen in the way that that disease looks, to help keep somebody receiving the services until they die. So as long as we can preserve their life until they die. See, there may be one other note in the chat. You're welcome. Are there any questions around eligibility? Can get very, very, very messy. So what keeps somebody on? One of the things that I wouldn't necessarily, unless you really like some light reading material at night, CMS has what's known as the conditions of participation for hospice. And so it really, really like gives you line by line by line what some of those requirements are. And some of it is really related to disease progression, and some of it is related to the kind of care that we provide. So I encourage that for anybody who has insomnia and has a hard time falling asleep. Feel free to read those conditions of participation, but also feel free to ask your teams if you have yourselves or a family member receiving hospice care. The other big myth is that hospice focuses on just the patient. And this is another one, because I oversee the patient experience department, the department that actually I oversee and the people that I oversee are actually all of the counselors. So I oversee the volunteer departments nationwide, our bereavement department, which I'll talk about in a minute, our social workers, our chaplains and spiritual care counselors, and our music therapists. So for me, this myth is a really important one to make sure that I arm you all with. when we think about the term patient in hospice care, we think about in that circle of care chart at the beginning, we think about the patient, and then that next circle, the family, friends, or what I've been calling and referring to as the chosen family. That's the patient. For us, it's the unit of care. We talk about it sometimes as the unit of care. And so one of the things that's really important is that hospice agencies, as part of that rate that I talked about, so that capitated rate, that per day rate that you get for all of those services, pharmacy, or the medications, the durable medical equipment, all of the people, as part of that, one of the other requirements we have is to provide 13 months of bereavement support. And this can be extremely different from one hospice to the next, where everything from a patient's admission and eligibility and their recertifications that we just talked about, or those benefit periods, through the death are very, very, very systematic and outlined in many ways. The bereavement is just one solid requirement. You have to provide 13 months of support. You have to do a review of how the chosen family is doing at the time of death, and you have to do one shortly following. But how you provide bereavement care is completely and 100% up to the agency. And this is where things can be extremely different from one agency to the next. I can share a little bit about what we do, but it's not the same everywhere. And this is where things get really challenging, and where I always encourage family members, and I mean that by chosen family, friends, the community, to pick up the phone and call their hospice and ask for support for yourself or anyone else that was surrounding that individual, that loved one of yours, for this level of support. We provide 13 months post bereavement support in the following ways in our agency. We do assess everybody for different variations, especially many of us have seen an increase in some of the mental health needs and the counseling support needs, just the trauma that all of us as a community have faced through the pandemic. And of course, with everything else that's been happening, our own experiences, our own histories can really map that in different ways. And so in hospice, we look at 3 different levels of care for bereavement and counseling. And those 3 levels are known as what we constitute as a low risk, a moderate risk, and a higher risk. And that's in relation to prolonged grief disorder. So you're at low risk for this potential additional mental health need, a moderate risk, or a high risk need. And that changes very frequently with the right level of support. So you can be high risk one day, and then with the right level of support can maneuver through. So we provide at minimum 4 touch points to every single individual that either the patient identified or the chosen family or themselves identified. And so we'll do the first one within the first week following the death, because that's typically where a lot of shock sets in. Even if we're prepared, even if we're anticipating a death, that is the only time that person in that relationship to you will die. Right? There's never a second time, there's never a third time. So as much as we anticipate how we think we're going to do, we are never necessarily going to do that way, because it is the only time in our lives that that person, that relationship will die in our world, physically die in our world. So that's the first time, as we do a touch point at that 1 week. Then we do a touch point at 1 month, because what typically happens is most of us have returned to work if we're working. Most of our support systems that came in for a funeral, a homecoming, an honoring of life, a memorial, whatever ritual was done for the death itself to honor that individual's life, most people at around 1 month have gone. And so now you're kind of sitting with it. And so we'll always do a touch point at 1 month. And then we typically, depending on need, may have some other touch points between, or we do another touch point around 6 months and one at 12 months. And in the midst of all of that, we provide a lot of grief support groups, and those are available to the community. So if you've had an experience with a hospice provider that doesn't do grief support, but you feel like having other people who have experienced the same thing with you, virtual or in person, and you want to participate in a grief group, we always welcome the community at large to participate and look out for us. And that's those are published on our website. So a lot of hospices will do that. They'll publish their groups on the website. So I highly encourage people to reach out. I think I saw a couple of comments. Oh, maybe not. Any questions, comments around post-death bereavement support? One of the things that I think is the most important that we try to do before the death occurs is what we call legacy. And finding a way to honor that person in a way that's special to them, even if we only get a few days with them on service. 98% of our patients receive some form of a legacy initiative, and it's part of what counselors need to work on after the death with individuals who are grieving. And so we think about it, it's a physical, tangible thing typically. Sometimes it's like a memory bear where we've taken the clothes that the family has given us, the chosen family has given us from that loved one, and we turn it into a memory bear. And so it may smell like dad, mom, sister, brother, child, or we may create a thumbprint so that forever you have that. One of the things that, because we have music therapists in all of our programs, sometimes we'll do a heartbeat legacy, something that somebody did for my grandfather. My grandfather had very early onset Alzheimer's, very early in his late 40s. And so by the time he died in his late 80s, we had really had very few moments of lucidity with him where we could have an open dialogue, and he could share just because it had been so many years. And so having his heartbeat, to be able to hear that for the last time, and then to be able to hold on to that, it was set to music and we have that. So things like that, like it can get as creative as you can possibly imagine. And then one of the other big things that most hospice agencies will try to do is do a last wish. Find something that's important to the patient and their chosen family, and find some way to honor their life and live and celebrate that life and the togetherness that they have. Okay, big question, who pays for hospice care? And I know that this one came up early. So everything that's associated with a hospice diagnosis is covered by Medicare, by Medicaid, and private insurance. And in the event that somebody doesn't have coverage, we always try and assist by doing that. Many hospice agencies provide some form of a sliding scale payment, or what we call true charity care. One of the challenges is what hospitals can do in charity care, or indigent care, sometimes what it's called, and what hospice agencies can do is often very different. And that's always a place where we need to be really honest and open around that. But the team will help support and find I don't know what just happened, sorry, and find a way to talk through and help do a financial assessment with the family to either help identify other sources and resources that they have to provide care for their hospice benefit, or to identify whether they truly have the ability for indigent or charity care. So that's one thing I would say to anticipate for yourself if you're a patient experiencing or receiving the hospice benefit, or for a member of your family or chosen family, is dialogues around finances, so that we can really help you get all of the things that you are entitled to in that care. Okay, so this is typically what I teach to clinicians, and I'm going to share it with you because I think it's kind of important for you to know how we talk about how do you initiate a hospice dialogue with a patient and their chosen family. And if you have some recommendations, I would happily take them and add them into our list of items. The first is, and the most important one is, I used to teach a class, and I know I'm not supposed to swear in this, so I'm not going to, but it was lovingly referred to as sit the F down. And it was meant for clinicians to say, like, when you're talking with someone, whether you have 5 minutes or 30 minutes, sit down and have a conversation face to face, eye to eye, so that we are partners on this journey, and you know that we're partners on this journey. That is our goal. That is what we want it to feel like. And we are experts in what hospice and end of life care entails, but we are not experts in who you are, who your loved one is, and how they want to die. So it is really important for us to work together and be partners in each of our expertise. So the very first thing is being direct, being compassionate, and being honest. One of the big experiences we have is hospice clinicians and end-of-life clinicians and palliative care clinicians do this really well. Everybody else does this really, really poorly. For many, 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 many years, there have been studies that assess physicians specifically, so doctors specifically, in their anticipation of how long a patient still has to live when they have a chronic or life-limiting illness. And they overestimate the length of their life by 67%. And that study was first done in the 80s, and it's been replicated every 5 or 6 years with a very large population of physicians and patients, and it has not really budged any. And so I think the last study was a couple of years ago. And so that's where things can be really hard. So I always ask our hospice clinicians, sometimes this is the first time that patient or family is hearing the word hospice. Sometimes it is the first time they are hearing that that individual has less years on their life and less days on their life than they anticipated. So it is really important to be honest, direct, and compassionate, and to find out who they want involved in the dialogues and who should be involved in the dialogues. The other is the term healing, and this is, I think, a community partnership where we want to work together. Is the term healing often we think about as cure. And I think altogether in healthcare and in our communities, we need to start defining healing as having a different sense of hope in terms of what we can do until the end of our life. And so I think that's something that we need to do as hospice clinicians is do a better job of healing. The other is we sometimes use this language from medicine on like, what's your goal of care? What's your plan of care? And we forget that we're talking to community members. I think about my entire family. They typically send me to do all of the medical conversations. I'm not even a physician or a nurse. They send me to do those because I understand that language, the medical language. We need to get rid of medical language. What I want to know from you and from your loved ones and your chosen family is, what are your hopes and your fears? If a hope of yours is to be able to walk to get your own mail at the end of the driveway for as long as is humanly possible, well, dang it, we got to work on that. So, and that needs to be a part of our dialogue, even if my goal is something else for you. And then we always talk about thresholds. So everyone has one, and most of us don't think about them. And this is a really hard place to talk to patients and families in general, because most of us have never really thought about thresholds, meaning like when I can't do X anymore, or if I'm sleeping so much that I don't get to spend time with my family, then I know that I really want to be a do not resuscitate at that point in time, or I want a do not resuscitate order, right? So all of it's that conversation. Every one of us has a limit, and it's important to have conversations about limits. And then to think about us working together as partners in care. And this is, again, it's our responsibility to set the stage for us to be partners, not for us to be invoking or forcing something on top of our communities that we are honored and privileged to serve. And I think that one sometimes is a really, really hard one because we forget, we have such expertise in end of life care. We sometimes think, well, we've seen this 1,000 times. And I always try and remind people it is the only time that relationship in that way will have this kind of death and this end of life experience. And so it's important for us to get out of our own way as clinicians when we are initiating hospice dialogue. So I think this is important for all of you to know, is this is the way that most of our hospice teams are educated. Some of your best conversations are going to be with your spiritual care counselors and chaplains. They are very adept at having this dialogue. So sometimes we force them to go with our physicians or with our nurses. And the others are actually, the nurses very typically are very, very open and honest. One of the hardest things that I think is important for the community to know, and I don't have a slide on it, but it is in relation to who we're allowed to talk to and who we're not allowed to talk to. And that can sometimes be a big source of contention. there are laws in every single state around who gets to make decisions if somebody hasn't legally designated an agent for themselves or a proxy when they can't make that decision for themselves. And so I say that to the community because I want to encourage you to think about who you want to make decisions for yourself. I'm going to speak just for me as a human being and not as a hospice clinician. I have designated somebody who is not a part of my family on purpose. I want my family to be my family. And I want this person, if they have to make really hard decisions on my behalf, I want them to do that. Or if they have to honor wishes that were really hard for me to put on paper, or to tell them, I want them to do that. And I want my family to be my family and get the level of support. So that's the decision I've made. That's not right for everybody. Everybody has their own decision. But that is often the place where people really struggle. Like, for example, I'm the granddaughter of somebody, and I am not the legal decision maker in the state and county that my mom and my grandmother are in, let's say. And I don't get to have a say in that, even if I'm the person that has the most opinions, strengths, knowledge of that. And this is the place where I think it's really important to encourage all of us to have these dialogues, as hard as they are with our families earlier on. And I see, Kathy, you make unfortunately, you have a question that prompted me to say that. And I know it can be a really great service. And I'm saddened every time I hear that that's not been somebody's experience. You can absolutely in some scenarios. So for those who can't see, Kathy said that everything that we're talking about sounds really wonderful, but that's not always the experience that people have and hasn't been her experience. Her question is, while on hospice, can you request a new team or change in a team member that you clash with? So the answer to that is not so simple. So the answer is yes and no. And part of that may be dependent on the size of the hospice agency, right? We may not have the number of individuals to sort of circle out. If you need someone, that sometimes happens in smaller agencies where you just don't have another nurse to send or that other social worker or whomever else. Teams are lean most of the time, unfortunately. And sometimes we can't do it if it's on the basis of a scenario which may be construed legally or ethically as potentially discriminating in one direction or another. So in either the hospice clinician to the family or the family to the hospice clinician. So here's what I will say. You may have heard that I'm getting my doctorate in ethics. I lead our national ethics committee right now. I would say that if you're having that, two things as a community member, I'm going to empower and arm you with two things. The first is ask to speak to their manager and their leader and ask them to facilitate a dialogue or at least share with them what happened and see what they can do. And they should be honest with you about that and compassionate about that. And the second is ask for an ethics consult. Sometimes you want a complete third party out of that who isn't involved in the day-to-day. Every healthcare agency has to have access to either an ethics consultant or an ethics counsel. So ask for an ethics consult and get an ethicist to you so that you can have a dialogue with them. Or if they happen to be in a facility, this sometimes happens too. Sometimes we're told that we're struggling with a team member, but the patient lives in a skilled nursing facility, like a nursing home, or they live in an assisted living facility, and it's actually not our team at all. It's a member of that team. So the third thing, I said two, but I'm going to give you one more, is ask for the ombudsman if they're in a facility. And so those are three ways to at least start the dialogue so that clash doesn't happen. No one should have non-compassionate care at the end of life. And I'm very, 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 I very much believe in that for any patient or family. I know we only have a couple of minutes left, so I just want to show you a couple of questions that may come up and then tell you how you can make a referral for hospice. So this is just a cultural humility. We call it a cultural humility outline, but it's really 6 different sections of conversations that we try and have with all of our families. Not every question here would be asked, but I'm going to draw your attention to a couple of questions that may be asked so that you can really, and a couple of elements that may be asked, so that you can sort of see how the lines are drawn across some of our conversations. So the first one is I use the conversation of threshold. So, oh geez, I forgot. If you look down on the left under considerations for advanced directives, and yes, I will happily share this, and Compassion and Choices can share this as a PDF with all of you after. You'll notice that there are questions around conversations related to final wishes, do not resuscitate, orders, and so it's a question around how are those conversations related to these things best initiated with you and or your chosen family. And so that's a question you should often expect to hear. You should hear questions around pain and symptom management and previous experiences in healthcare, especially since we're talking about chronic illnesses or life-limiting illnesses. So there's probably been another experience or two before. And you should hear questions around advanced care planning, or advanced directives is sometimes the language used, which again, I highly encourage everybody to do. I know that that's not appropriate for every cultural background, faith, or belief system, but for those where that isn't a barrier, I highly, highly encourage having those dialogues. And do not resuscitate as a conversation often had. And so I have always led these conversations using a question similar to that. And so this is where the threshold question comes in, is when someone says, I'm not ready yet, I don't want to talk about DNRs right now. Then I'll ask the question of, is there something that's a key to the quality of your life? Something that's really important to you that when no longer possible indicates a time to discussing your final wishes. And I promise that I'll come back to that. So I don't ignore that dialogue forever, because every single day something different may happen, or as an individual, or as I get closer to the end of my life, I may cross that threshold, and it may be more important to have the final wishes conversation before the other. The other is thinking about what suffering means to each individual. I always ask that question. People have extremely, extremely unique and varied responses to it, but it gives me a good key to that individual. I also really want to know about the family structure. So telling me who makes decisions, what's important. I come from the Ukraine, where typically you don't share with the patient that they're dying, but in the United States, if I still have full decisional capacity legally, I have to, as a healthcare provider, share that with somebody from my background. But I want to know who makes decisions, because I want to include that person. Who do you want to be involved? I want to include that person in the conversation. So again, I will share this with you, but these are some of the typical questions you could expect to see and ask. And they would be a part of the experience, not the first day necessarily, but throughout getting to know and build rapport and build a relationship with your hospice team. And then the last item here, I know we're right 1 minute, is how to make a referral. So this is typically what I teach, how to make a referral from the physician or the hospital scenario or the healthcare provider. But for families, it's important to know that you can just pick up the phone and call your hospice agency if you think that you or your loved one is potentially eligible for the hospice benefit. Pick up the phone to a local hospice. They're really easy to find. Google them locally. Ask somebody, if you're not tech savvy, I'm not terribly tech savvy, ask somebody, hey, somebody, I guess, younger or more tech savvy in your family or community circle, hey, can you look up the hospices around here? I'd like to call. And they'll tell you and walk you through. They have to do an assessment to determine whether somebody is eligible for hospice services. So they'll tell you. So there's no shame or harm in picking up the phone if you think somebody that you love is eligible, or you yourself are eligible, and having them come out and talk through what they do, how they can support you, what their team looks like, and to just evaluate for services. And I think I see one question. Is there any conversation within the hospice community about the growing understanding about end-of-life use of psilocybin or LSD? Yes, there have. There have been a lot of dialogues around uses of LSD and psychedelics in the hospice community. And there are lots of conversations depending on the state that you live in, related to various different other acts or things that are available to patients in end-of-life care. What I would say to that question, Susan is, I think it was Susan, forgive me, is please ask the hospice agency where they stand on those issues when you're calling for a referral or when somebody's coming out. It's really important for you to know that your hospice agency is aligned with your own beliefs. And if they aren't, if they may be aligned with your own beliefs, but it's not legal in your state, then it's important for them to be able to share that with you too. So please, please, please feel free to ask them those questions right up front. But these are a couple of our favorite legacies, which we love to do because it's important. One of my favorites is the one in the middle, and it is truly, this one I believe was a couple, and we spent time as we untook off that, like where we took off that larger mold shell off of it, we got to have a lot of those conversations with the questions. And so I really got to know about who this person was and their life story and what they wanted to leave as a legacy. All right, I can stay on for a couple of minutes. I see continued dialysis, blood pressure medication, good. Okay, so Joan asked or made a note around different kinds of medications that could be continued or may not be. So the very, very simple answer to that, Joan, or the very simple language around that is, if it's used for the palliation of symptoms, so it'll help somebody feel better and it's connected to their hospice diagnosis, we will continue to do it for as long as it is not, as long as it is indicated. Once it starts creating more harm than good, then the conversation may shift towards discontinuing some of those medications, because now it's creating different kinds of harm. It could create pain, it could create new symptoms that may be non-favorable to an individual. So, and each of them is very specific and very nuanced depending on the patient's diagnosis and the individual receiving care, and some of the other diagnoses they may have, what we refer to as comorbid. So sometimes the conversation is around continuing dialysis, sometimes it's around discontinuing if it's causing more harm than it is benefit. And that's a really, really, really important conversation to have. The other thing is that sometimes we talk about specific, like legacy, we sometimes talk about specific elements that are important, like I want to live to see my daughter's graduation. And so maybe we will continue things like nutrition or hydration or dialysis until we hit that. Maybe that's my threshold. And then we may start a conversation about discontinuing. I hope that helps. And then Sarah, I think you've got the last one here. And of course, you're throwing out a big one. If the patient opts for VSED is voluntary stopping of eating and drinking. Can the hospice be called before organ failure begins? As in dementia, are you asking that because this is also an individual who's an organ donor? Are we trying to harvest organs for this individual so that we can preserve them for as long as is possible? Oh, the patient is trying. So this is one of those conversations. Voluntary stopping of eating and drinking is definitely one of the conversations to ask your hospice provider what their belief system or what their thoughts are in the way that they support. We do support VSED in our agency. We also, in states where it's legal, we support medical aid in dying for our patients. But there are lots of agencies that have other institutional policies or are following other healthcare policies that are legal to them, like certain religious directives that don't allow them. So it's important to ask about that. Yes, you should. You can absolutely call hospice before organ failure sets in. To be honest, sometimes hospices get calls and the patient is literally in the last few hours of their life and will still try and support. What's really, really important is to feel empowered to make your needs known and your family's needs known, and to ask the questions about the things that are most important to you so that you can make an informed and educated decision. I know we went a little over. I really, really, really hope that helps. Please, please, please feel free at any point in time to reach out. Compassion and Choices can absolutely connect you to me. I can connect you to other members of our teams in Florida if you have additional questions, but I'm always, always happy to help support the community. Thank you. I know this is a really heavy topic to talk about, but having a beautiful and good death is absolutely possible for 100% of the individuals who are closer to the end of their lives than they are to the beginning.
Thank you so much for going through all of that. If you do have questions, please feel free to reach out to us. And my email and phone number is actually in the chat box, so please do look at that. And if you do have questions, just make sure to email us. I would like to thank you all that were able to join us. And thank you so much, Yelena, for joining us today. You covered so much important information and we're so thorough with all the questions. If you do have any questions, again, reach out and just look at the email in the chat box. We hope you had a wonderful time joining us and we look forward to seeing you soon. Our next event will be in February, and we will be actually talking about voluntary stopping eating and drinking, otherwise known as VSED. So we look forward to seeing you there. I do see a question in the chat box, but the main thing is it will be sent over. All the information that we did discuss will be sent in an email. Take care, and thank you so much for joining us today.